are presenting family dynamics and crises. It's myself, Courtney Farland, Bokang Saboka, and Dr. Nyatsela Mhlongo. So to start, we need to understand what is a family. There's many definitions for a family. The Oxford Dictionary formally defines a family as a group of one or more parents and their children living together as a unit. However, we know that not all families fit into this definition, and therefore many more exist. A more inclusive definition would be any group of people related biologically, emotionally, or legally. Another example of a family would be a particular grouping of people who tend to interact and live with one another and are bound by kinship, marriage, or adoption. So what is the purpose of a family? The family is responsible for the basic needs of its members, and this is obviously in order to sustain life. It's also very useful in providing protection from hardship and illness, especially to younger members of the family and elderly members of the family. A family also instills a sense of identity and cohesiveness for that particular group. And it also importantly creates an environment for education and socialization. So considering the above points, one can understand how the family plays a crucial role in health and disease. So what are some healthy characteristics of a family? The list is very extensive, but it includes good communication between all members, personal autonomy for each person, flexibility within the family unit, appreciation for one another and the roles that each member plays, support networks both internally and externally, family time and involvement, spousal bonding, growth personally and as a family group, and spirituality and religion can also play a supportive role. So what is the South African family? This is definitely not your typical nuclear family that may come to mind, because South African families present with a unique set of challenges. So examples of these challenges may include migrant labor, whereby there's a lack of stability and consistency in the household. Single parent households are also common and are usually headed by women due to abandonment of the other parent. There's also grandparent-headed households, which result in the absence of a middle generation. Unfortunately, there's also a high burden of HIV, resulting in many child-headed households. South Africa actually has a comparatively high divorce rate, so that also results in much conflict in the family. Unfortunately, we also have an increased prevalence of child abuse and domestic violence. Just handing over to Nyatsela now.
So I'm going to build on what Courtney just explained to us about how families can be defined in terms of them being sanctioned kinships that are of varied dynamics, by showing how the intimate nature of that system makes it pivotal in how a person grows and experiences life. And thus it makes it a basic unit of illness and health. There's also a point of how unexpected events such as illnesses or divorce, separation, or even anticipated changes or transitions in life, in different stages of life, can affect the entire family system. And those can be the underlying or precipitating factors in how people present to healthcare facilities. Next. So this is a table, the life cycle stages. It shows the major tasks that are involved in each of those stages, as well as how a family can adapt in a healthy way to those changes. And so if it's unable to do that, that would result in some sort of crisis. So it is a useful tool in trying to in trying to map out the it's a useful tool in mapping out the roles of different family members, as well as to anticipate and understand various difficulty that each member might be facing at that time. Another tool that can also help illustrate family structure is the genogram. It's helpful just because it accounts for every individual in the family. It includes people who are absent or deceased. It shows what their roles are in the family, their relationships between each other. And it also shows patterns of illness and psychosocial relations between those people. It can show origin of symptoms, and it can also be a preventative tool in helping us identify potentially risky patterns of behavior. Next slide, please. Thank you. So the following is a list of presenting complaints. So this would be a result of a breakdown in the hallmarks of a healthy family, and people commonly present as having marital or sexual difficulties, patients that are known as a difficult patient, the thick file syndrome, where either a single member of the family or multiple members of the family keep presenting, usually with non-specific symptoms, and abnormal behavior in children, which can include psychiatric disorders, as well as other behavior like truancy in school, being known as the naughty child. There's also evidence of abuse. This can be physical or emotional, and inappropriate behavior in and around pregnancy as well. Next slide, please. Okay, so this isn't showing, oh, okay, it is showing well. This is the Psychosomatic Illness Iceberg. It's a tool for extrapolating how a family system can affect how a patient presents. So the family is the environment in which a person develops, and that affects their values, as well as their personality, and all of those underlying traits can then affect how they present. So in terms of their somatic symptoms, and their behavior, like the sick role that they adopt when they present. Next. The following is a diagram. So it shows, it's a multi-level illustration on different triggers of stress that can lead to a presentation in crisis. Like I said earlier, it could be events that are not anticipated, as well as anticipated events. On the larger society scale, it includes things like racism, sexism, homophobia, poverty. And then on the community level, it can be affiliated with work or leisure and inability to work, which is a concern in our country with regard to unemployment rates. Different dynamics within extended families, the immediate family, as well as the individual. Next. So part of that growing environment that influences how a person develops is the family systems concept, which includes what's listed below. So they look at family at the level of hierarchy. So this shows who is responsible for making decisions in the home. It accounts for whether people are heard or not within the home, boundaries, whether they're clear and healthy, or if the boundaries are obscured or non-existent, which creates a very volatile environment. There are symptom bearers, scapegoats, the parented child, which we're familiar with, as well as alliances. Alliances are bonds between certain members of the family, which are not necessarily a bad thing. Then there's coalitions, which are alliances that may become aberrant when people are bonded against someone else in the family. Enmeshment, where people aren't allowed to express their autonomy within the family in a healthy way. And this can also be seen in the consultation, for example, when a family member won't leave another family member, or we've seen it with our foreign patients as well, where one of the family members or the partner does not know how to speak South African languages, and they require the partner to speak on their behalf. So all of these help us to recognize individuals that could be vulnerable, and they give us an opportunity to intervene earlier on. When I hand over to Boka.
Hi, everyone. I'm going to then discuss the consultation. So working with a patient and their family can be a bit difficult at times because there are multiple dynamics to take into account, as my colleague Nyatila had just mentioned. So first, we need to assess each participant's role in the consultation. So the family member's role is to offer support to the patient in circumstances where there's a poor prognosis, or if a family member feels safer talking to the clinician with them there, so they provide a sense of emotional support for the patient. Some family members are usually present during the consultation in the case of pediatrics, where the patient can't really speak for themselves, or the family member is a primary caregiver, and that would be the same for geriatrics who have chronic illnesses. Another and ever-prevalent reason a family member may be present during visits may be due to them needing someone to translate, so immigrants who don't speak a common language with the patient and the doctor, or it could be due to cultural or religious beliefs, and each of these need to be taken into account by the treating physician and respected. As I've mentioned, there may be varied reasons why family members are present in the consultation, and all of these provide an opportunity for collaboration into patient care and provide patient accountability. There is risk, however, for malicious intent, which the clinician should keep an eye out for. On the right of the slide, you can see that this is basically a picture from the American Family Physician Journal, and it basically shows the different roles that each family member plays during the consultation. So some of the roles is either to advocate for adequate patient care, to express their issues or concerns regarding the disease or the patient's condition or the impact of their condition, to assist with the decision-making for those who cannot, as well as keep track of treatment for those who are primary caregivers of their patients. It's for them to interpret when necessary, where both the family member, doctor, patient, and are all able to be on the same page. Next slide, please. So from the same article from the American Family Physicians Journal, they had essentially said that the physician's role is to acknowledge the family member's presence during the consultation, to try and assess the dynamic of their relationship early on, to listen to the family member's concern over the patient and their condition, and in certain circumstances, assess for any signs of abuse and injury. Next slide, please. So to approach the consultation, the following tools can be used to help assist interviewing both the family and the patient. So by having both a patient and family-centered collaborative approach, it has been studied that the patient outcomes have improved. The practitioners should take into account the family as a whole's religious beliefs, culture, dynamics, and interpersonal relationships, and equip them with treatment plans that all parties agree on, using their own level of expertise. By doing this, the clinician makes it clear that the patient is being treated instead of their ailment, and this in turn leads to a more positive approach from the patient regarding treatment and possibly more improved outcomes as well. Next slide, please. Legal issues of families. So as healthcare workers, we're aware of the very difficult family dynamics that happen on a daily basis. A way of alleviating this problem from surfacing during a consultation, which may lead to uncomfortable patients and unfavorable outcomes, is to perhaps have a screening tool available. Initially, consult the patient alone. This gives the patient an opportunity to let you know if they are in distress and if they are comfortable with having their family member present throughout the consultation. Assess as best as you can if the patient is safe and that the family member is acting in their best interests. This is mostly important, especially during pediatrics. Another option is to perhaps consult the entire family as a whole initially, and then afterwards ask for some time alone with the patient to discuss the above mentioned points. Or in the case of suspecting neglect or abuse, to physically examine the patient and then make note thereof. In some cases, the clinician can ask the patient if they're in need of social or psychological support, and then if necessary, refer them to the relevant parties to assist the patient in help getting the help that they need. Next slide. The last topic that I need to discuss is the approach to acute distress. So there are very many situations where a patient may present with an ailment precipitated by a family crisis. The clinician needs to develop a stepwise approach to an acute crisis and learn how to diffuse the situation as best and as safely as possible. According to the American Association of Family Physicians, here are the 5 steps to crisis management. Step 1, develop rapport with the patient and reassure them in their crises. Make use of active instead of passive listening to ensure that the patient feels that their crisis is understood. Step 2, assess how severe the crisis is by taking into consideration the patient's emotional, physical, and psychiatric status. Step 3, ensure that the patient is safe either via hospitalization, voluntary or involuntary, and perhaps also ensure close monitoring of the family with assistance from the social worker, perhaps even placing them in a safe house, thus removing them from a dangerous environment. Step 4, try to neutralize the patient's emotional status and help them develop an action plan for the said crisis, which they can then use to follow through. Step 5, follow up with the patient to provide ongoing support and reinforce appropriate action steps that were decided upon in step 4. As you can see on the side, essentially what I had mentioned were the 5 steps for acute distress. This is just a diagram stating the same thing. Thank you.
Great, thank you. Perhaps I can get some comments from the 2 registrars who are with us. Anne left, and Shane left as well. Shane, perhaps you can add some value to this discussion. What are the useful approaches in family medicine to deal with families that you think useful?
Prof, so a really good presentation. Thanks, guys. Enjoyed that. I think you covered a lot of the bases. And then, yeah, I definitely like the way that you used Ubuntu and community. And so we always consider that as in family is not necessarily a bloodline per se, but sort of nuclear, and there are different definitions. And then when you start to think family, you always think of sort of systems or levels of care in proximity to the patient. And so with family-oriented primary care, then definitely assessing the patient, seeing where they're at, how they feel about the family, mapping it out with a genogram or socially with an eco-map. And so you could sort of see challenges, areas to work on, and strong points as well. And then certain situations would help for family discussions or family meetings. And that's with tricky cases and so on, and obviously with consent and agreement with the patient. And yeah, I'm not sure if I left anything out, Prof.
There are 2 tools that I think kind of useful to get a sense of family, and the one is the APGAR, which I think I put out there. The other one is called Scream, which I think is just getting you to understand the different elements of a family. So the APGAR, and maybe I'll just quickly show you. The APGAR is basically, you know, how do families relate to each other, and and in particular, the way in which they get help. And I think that's useful. There's also partnership in terms of, how they communicate with each other and whether they support each other in their growth. Have they been growing? Now that's part of it. And then the affection is actually whether there's emotional content within the family. So if you look at this, I think, and the resolve is really sharing of more than just, time and space and money, which is more than just sort of assistance and communication. So I think if you look at these, they can be quite useful to sort of think through that in terms of questions. The Scream is also a tool that I think useful. I'm just quickly looking for one that could be useful to put out. Let me just see if I can expand that. And they're basically trying to get you to understand different elements of the sort of mix of things. I think here's a good space or place you can get it. But it's thinking through what are the elements or the resources particularly that families provide. And Scream basically helps you to think through, well, there's the social interaction, which is there. Cultural pride or cultural issues can actually be very important in families, how they negotiate those kind of things, which are intangibles, but kind of handed down generationally. Religion is as much part of family, and you need to actually understand the religious aspects of that family. Economic is money and the like. Education is also important because it helps ways in which there is a resource. So all of these are essentially things within the family that are resources, and that you can explore. And then medical is in fact that they have resources as a family to achieve medical health. So I think this is also helpful for you to negotiate. So hopefully that can add to the discussion. Thank you very much for that. I can just share this quickly so you can have a look at that more closely. Right, great. Thank you very much. Thank you very much to the group.